So when we see a cirrhotic liver on ultrasound, we then have to right away look for clues of portal hypertension. So with portal hypertension, the liver is diseased. The liver parenchyma develops resistance to blood flow. This increases the portal venous pressure. Eventually, the portal flow will slow down and it will reverse, and flow will actually be going away from the liver, hepatofugal, and there's then increased risk of bleeding because collateral vessels open up. The ultrasound findings of portal hypertension include ascites, a dilated main portal vein, splenic vein, or spiromesenteric vein. What is a dilated portal vein? Well, a portal vein bigger than 13 millimeters in diameter we consider dilated. A splenic vein or superior mesenteric vein centrally, when it measures more than 10 millimeters, we consider that dilated. So just a simple measurement. We look for collaterals. Splenomegaly is part of it, and various Doppler findings. Where would we look for collaterals? Well, right away, the first place to go is the gastroesophageal junction, GE junction. We then can look for a coronary vein, which would be a little branch off the main portal vein or off of the splenic vein. We would look for a recanalized umbilical vein heading towards the umbilicus. We can have gastrosplenic vessels. We can have a splenorenal collateral. We can have a gastrorenal collateral. We can have perisplenic, all kinds of retroperitoneal collaterals, vessels that we don't usually see suddenly appear. So we try to look for them. On ultrasound, here is the aorta, the gastroesophageal junction, GE junction, and tortuous serpiginous vessels in the region. These would be the gastroesophageal collaterals. Here is a sagittal section through the recanalized umbilical segment, recanalized umbilical vein, and it has flow heading out of the liver towards the umbilicus, hepatofugal flow out of the liver. In this image, we see the splenic vein, which is posterior to the body of the pancreas, and it seems to have a branch. We usually never see a branch there, but when we see such a branch, that's a perfect place for a coronary vein. Here's a spleen with large vessels around it, up in the left upper quadrant. Perhaps these are gastrosplenic collaterals. Here's perigastric or perisplenic kind of collaterals. Here's a large spleen with the left kidney, and there's a large tortuous vessel in between, a splenorenal shunt. What are the Doppler findings in portal hypertension? Well, let's look at the portal veins. First of all, we're going to lose the respiratory variation. The waveform becomes very flattened. We have a drop in the velocity of the main portal vein, and eventually it may reverse and be on the reverse side hepatofugal flow. Hepatic veins start to lose their normal pulsatility. We had systole, diastole, kick, and now all of a sudden it's becoming a very flattened waveform. Hepatic arteries, the only thing we'll see is that they can become quite large. And also notice here on this color image, the hepatic artery is red, the main portal vein is blue. They're opposite colors. The artery and portal vein should be the same color. This means that the artery is going towards the liver and the vein now has hepatofugal flow. So we can see that as two different colors. You can also see enlarged hepatic arteries in the parenchyma of the liver. And what happens in that situation is in the portal triad, where you have the little portal vein, on top of it is dilated a little hepatic artery. Now also sits there the bile duct. Usually when we see a dilated duct on top of the portal vein, we see this this parallel channel arrangement. But it can also be seen with a dilated hepatic artery. We turn on Doppler. One has venous flow, one has arterial flow. Now, the last segment that I'd like to talk about the liver is regarding liver masses. Ultrasound is excellent in detecting focal liver lesions. We're very specific. We're specific for liver cysts, but liver cysts that are about 1 centimeter or more, because very tiny ones we may not be so sure about. But ultrasound is not good in differentiating among the different pathologic entities. There are very few ultrasound features outside of cysts that are characteristic of the mass itself, the pathology. We are not good in distinguishing between benign and malignant masses. Triple face liver CT and MRI are excellent modalities for this, but we are good for picking up a focal mass, and we are also very helpful in the diagnosis in the proper clinical setting. We're good for follow-up and as a guidance for biopsy. We can see simple cysts. Now, this is a classical cyst like anywhere else in the body. Anechoic mass, smooth margins, excellent sound transmission. So this is a simple cyst in the liver. What else can be simple cyst? Well, an old hematoma, a hydatid or echinococcal abscess, which this is. This is a patient from Egypt who had a solitary cyst, and eventually this was diagnosed to be echinococcal. A biloma or a seroma can look like a simple cyst. And if we ever have a vascular structure, or if we ever have a cystic structure that looks unusual, not perfectly round, we should always think of the possibility of this being some type of vascular structure like an aneurysm or some unusual fistula like arterial portal venous fistula or portal to hepatic vein type of a fistula. We can have multiple cystic lesions throughout the liver. Very often these are associated with adult polycystic kidney disease or the dominant polycystic kidney disease. We could see multiple cysts with echinococcosis or hydatid disease, as was in this case. We can have multiple cystic lesions throughout the liver that are actually choledochal cysts, the type 4 and the type 5. Type 4 has the dilated bile duct. Type 5 has a normal bile duct. But we can see these cystic structures throughout the liver. If we look at them closely, we will realize that they actually connect, and these are tortuous tubular structures. But many times they just look like collections of cysts.